Hello, and welcome to this four-part continuing education course on guidelines for best practices in concussion management, the development of position and consensus statements. Over the next four presentations, we will discuss the nature and development of clinical practice guidelines as a component of evidence-based practice. We will then specifically transition to the development of both the NATA Concussion Position Statement as well as the most recent Berlin Consensus Statement. Lastly, we will focus on how clinicians should evaluate concussion statements to determine their applicability for use in their own clinical practice. Clinical practice guidelines are systematically developed statements to assist clinician and patient decision-making about appropriate health care for specific clinical circumstances. They are developed using standardized procedures to improve the quality of patient care delivered. Historically, they have been developed based on clinician expertise and clinical judgment. However, with the shift towards an evidence-based approach to healthcare, there has also been a shift in focus towards the development of evidence-based clinical practice guidelines. An important question is to differentiate between various terms, including clinical guideline, practice parameter, and standard. These phrases, including protocol, practice parameter, pathway, standard, consensus statement, are used in many different contexts and may not necessarily represent a true clinical practice guideline. If we look at the Institute of Medicine's recommendations of how guidelines should be structured, they should be valid, discussing the condition intended. They should be reliable and repeatable over time. They should be clinically applicable for various clinical settings. They should be flexible, which allows the clinician to alter components of the guideline based on individual patient needs or certain clinical circumstances. They should be clear and provide specific and distinct directions regarding the treatment, management, or diagnosis of a particular condition. They should be developed with a multidisciplinary process to include the perspective of healthcare providers from different disciplines and fields. They should be scheduled for periodic review to determine whether or not the information provided in the guideline is the most currently up-to-date information, and they should be well documented with evidence from the medical literature. In an early article proposed by Eddy, it was also discussed that guidelines should be accurate, which means they should produce the health outcomes that the developers intended. They should also be accountable, which includes rationale for the recommendations, the evidence on which they are based, which should be clearly provided and referenced within the guideline. They should also be predictable, where both clinicians and policymakers can anticipate the health and economic consequences that arise when a guideline is implemented into clinical practice. Guidelines should be defensible and should provide the information necessary to resolve conflicts with other guidelines. This will become important as we discuss some of the differences in the various guidelines related to concussion management. And lastly, they should be usable. Clinicians should be able to tailor the guideline to individual patients and practice settings as they incorporate the evidence and the guideline into their clinical practice. If we look at the purpose of clinical practice guidelines, these are to describe appropriate healthcare based on the best available scientific evidence and broad consensus, with the goal of reducing inappropriate variation in practice, one of the key areas which drives evidence-based practice. They should also provide a more rational basis for referral to other healthcare providers, referral for imaging, or for other types of testing. They can provide a focus for continuing education for clinicians from various healthcare disciplines and promote efficient use of resources, whether those are financial resources or personnel resources. They can act as a focus for quality control, including audit or other quality improvement initiatives. This is an important area of practice and one of the core professional competencies of continuous quality improvement. Clinicians should be able to review their own medical documentation and judge it against clinical practice guidelines and other statement points to ensure that they are practicing and documenting in a manner that is best for them as well as their patients. And lastly, clinical practice guidelines can assist in the development of new research agendas by highlighting the shortcomings of the existing literature and suggesting appropriate future research directions. If we look specifically at concussion, an area where we are definitely starting to see this is in the area of concussion treatment, where we are moving away from the strict rest paradigm into one assessing various treatment protocols, rehabilitation techniques, and active rehabilitation. Furthermore, from a diagnosis standpoint, we are seeing the importance of oculomotor assessment becoming that fourth leg of the stool, along with cognitive, balance, and symptom evaluations. If we look at this figure, it demonstrates some of the potential benefits of the incorporation of clinical practice guidelines. These include benefits for the patient, such as quality of care, improved health outcomes, improved consistency of care, educating or informing patients about what clinicians should be doing, empowering patients to be an active part of the decision-making process, can influence public policy, and promote distributive justice. For healthcare professionals, the use of clinical practice guidelines can result in better quality of clinical decisions, reassurance to clinicians that their practice is appropriate, providing explicit recommendations to assist in guiding care, reducing outdated, ineffective, or wasteful practice, supporting quality improvement initiatives, as well as informing research agendas by highlighting current gaps in the evidence. At a healthcare system level, the use of clinical practice guidelines can improve efficiency, optimize value, and demonstration of adherence to guidelines may assist in improving public image. As guidelines are developed, minimal criteria should include explicit statements that explain the process of creating the recommendations and the development of the guideline, including a systematic search and gauging of the evidence. If this information is lacking, one should question the validity of the guideline. The subject area and the need for the guideline should be identified and defined, with gaps in the existing literature highlighted. The writing or development group should then be created and the members of group and their specific roles identified. Further, rules for identifying and assessing the quality of evidence are determined prior to searching for the evidence to ensure an unbiased search and inclusion of studies that warrant or meet the inclusion criteria. A method for translating the evidence from different types of studies and from studies of different methodological qualities should be included in the guideline. And lastly, guidelines can only be as good as the most recent evidence. Therefore, as new evidence is identified, guidelines should be revised and adjusted to ensure that they are based on the most recent current evidence. Many organizations provide a specific timeline in which each guideline should be reviewed. Now, there are many different types of clinical practice guidelines. And this slide aims to summarize the four primary categories. The first is expert consensus or global subjective judgment. In this category, the guidelines are primarily developed based on the opinions of experts and not necessarily including a full systematic search of the evidence. These are by far the simplest, fastest, least expensive, and most accessible method for setting a guideline or policy. However, this does result in a lower level of applicability and may reflect biases of the experts in their professions in determining what evidence is included, and what recommendations are made. The next level is the evidence-based guideline. In this approach, it is explicitly described the available evidence that pertains to a policy or guideline and ties it to the current body of evidence. There are 5 specific steps in the development of evidence-based clinical practice guidelines. First, the subject area and the need for the guideline are identified and defined. Second, a development group is created. Third, the rules for identifying and assessing the evidence are determined, followed by a method for translating the evidence from the different types of studies and different methodological approaches. Lastly, there is a discussion and specific timeline for follow-up reviews identified. Moving on, outcomes-based guidelines are the next level. These guidelines are similar to evidence-based guidelines, but also include a measure of the effectiveness of the evidence-based recommendations to determine whether they improve quality of care. This can be through the use of meta-analyses, decision analysis, or cost-effective analysis to assist in determining effectiveness. Now, it is important to note that assessing the benefits adds time to the development process, but it does allow for a greater applicability of the recommendation of this type of guideline. Lastly, the most rare type of clinical practice guideline is one that is called preference-based. This method of evidence-based and outcome-based guideline are combined with patient preferences for possible outcomes of interventions. We know that patient preferences have been described as a person's views about quality of life experienced with different health states and can be used in applying treatment decisions to individual patients. Now, the inclusion of patient preferences further makes the guidelines difficult to create, but does provide the only form of guideline that takes into account the variability in the values of individual patients and includes the patients in part of the decision-making process. In healthcare, there are very few clinical practice guidelines that have included the patient preferences. One that has is an Agency for Healthcare Policy and Research Guideline for the Management of Benign Prostatic Hyperplasia. In this guideline, it was concluded that patients' choices need to be elicited and that patients and healthcare providers should share the decision-making regarding the different treatment strategies for this particular condition. Now, when we look at the types of guidelines that athletic trainers often use, primarily being NATA position statements, as well specific to concussion, the international consensus statements, these documents tend to fall somewhere between the expert consensus and evidence-based, with more recent iterations leaning more towards the evidence-based. With the NATA statements, while there is a literature search done, it is not always done in a manner that sets up a priori many of the search strategies, search terms, development of risk of bias tools, and other items that are often seen with a systematic review or a meta-analysis. Now, one thing that is important to note is that the implementation of clinical practice guidelines does not guarantee that the recommendations will improve the outcome for an individual patient. There is still variability within each patient, and specific to concussion, this may be even more so. There may also be barriers to implementation of certain recommendations due to the environmental constraints of the athletic training facility, financial constraints, cultural differences, or lack of knowledge regarding performance, which makes it difficult to convince administrators and others that it is important to include or mandate certain components of a clinical practice guideline. One area where athletic trainers can get information regarding various guidelines is through the National Guideline Clearinghouse. This is an initiative of the Agency for Healthcare Research and Quality. and the goal is to provide physicians and other health professionals, as well as healthcare systems, accessible mechanisms for obtaining objective, detailed information on clinical practice guidelines, and to assist with the dissemination, implementation, and use. Within the National Guideline Clearinghouse, clinical practice guidelines are defined using the Institute of Medicine definition discussed earlier. However, not every guideline can be included in the NGC repository. In order to do so, they need to meet several inclusion criteria. The first being that the guideline contains systematically developed statements and recommendations that can assist healthcare practitioners in making decisions about healthcare for specific patients and clinical circumstances. The second is that the documentation associated with the clinical practice guideline can be produced and verified, that several components, including a systematic review of the literature and review of existing scientific evidence, was included. The full text guideline is then available upon request in the English language. It is current and has specific dates for revision, and documented evidence can be produced or verified that it was developed, reviewed, or revised within the last 5 years. It also should be noted that the guideline was produced under the auspices of medical specialty associations, relevant professional societies, public or private organizations, or government agencies. A clinical practice guideline developed and issued by an individual not officially sponsored will not meet the criteria. The National Athletic Trainers Association has had 3 position statements that were included in the National Guideline Clearinghouse. If we look quickly at the NGC website, under a quick search for concussion, we will note that 8 results were identified. This is just a screen capture of the top 3, including the evidence-based guidelines developed by the American Academy of Neurology, guidelines from the Ontario Neurotrauma Foundation, and the Veteran Affairs Department of Defense Clinical Practice Guideline for the Management of Concussion or Mild Traumatic Brain Injury. Moving more specifically to NATA position statements. These are documents that are intended to declare the official NATA and NATA Foundation stance on an approved topic based on current literature and practice. While these are not formal clinical practice guidelines, they are the closest thing that athletic trainers have to CPGs. These include clinical recommendations and considerations for athletic trainers and others practicing with athletic trainers. The recommendations are intended to be stand-alone statements that include an evidence category using the sort criteria. Following the list of recommendations is a background literature review that is a reference review of relevant issues related to the position statement and follows the subcategories of recommendations. The writing teams are encouraged to focus on papers with the highest levels of evidence, and evidence-based information should support each of the recommendations. This flowchart is developed by the Pronouncements Committee to demonstrate the process of developing an NATA position statement. This is beginning with Phase 2 once a topic has already been identified. The Pronouncements Committee reviews ideas and invites a lead author to work on that particular topic. The lead author then determines other writing group members and submits those to the Pronouncements Committee for approval. The writing group then has 1 year to complete a draft, and the lead author may choose how to lead the writing group and how to distribute the writing and responsibilities to the members of the group. There is then a several staged review process that includes the Pronouncements Committee, external peer review undertaken under the auspices of the Journal of Athletic Training, as well as reviews by the NATA and NATA Foundation boards. Lastly, with publication, an executive summary is published in print and the entire document is published within the Journal of Athletic Training website. As you can see, it is a very long process that often takes 3 to 4 years from the initial idea for a position statement topic through the complete development and publication of the actual statement for use in clinical practice. One thing to note is that every NATA position statement also includes a disclaimer. And the disclaimer is really to ensure that athletic trainers as well as the public are aware of the role of a position statement, which is to serve to promote awareness of certain issues to the members. It is neither exhaustive nor inclusive to all circumstances or patients. Several clinical circumstance variables, such as institutional human resource, state or federal statutes, rules, or regulation, as well as regional environmental conditions, may impact the relevance and implementation of various recommendations. It is advised that athletic trainers work with their directing physician and administrators to determine the best protocol to be used at their individual site.